Alrighty. So the Health in the Public Interest Program is a master's program at Georgetown University. We emphasize the social determinants and non-medical determinants of health. The seminar meets once a week. We invite students to invite others. We advertise the seminars through our channels, and you'll see that sometimes we get a really substantial and sometimes international audience for these talks. This first seminar is mostly students, understandably, but over the course of the year, it kind of steamrolls and we start getting more and more people, even as regulars. The shape that this seminar will take today, we have a student moderator. I encourage all the students to start talking to me about whom they'd like to moderate for over the course of the semester. So Amabella is going to do a formal introduction. Before we do that, I want to tell you how the seminar will run. The speaker will be talking for somewhere around 45 minutes. And during that time, she may likely invite students to participate to some degree. We'll follow this all up at the end by a question and answer period. That question and answer period can extend beyond the topic of the seminar to things about careers in public health or advocacy, etc., whatever you'd like to talk to the speaker about. And then once we've gone through student questions, we'll see if any people have things that they want to bring up from the more general audience. There is a chat function here. Feel free to enter comments or questions for later consideration in the chat. And at that, I will now turn it over to Amabella.
You mean Sophia?
I'm sorry, Sophia.
Oh, you're good. I was confused there for a second too. It's all good though. No worries at all. So
yeah, and I want to thank Sophia for stepping up to moderate this first talk, and she's doing it with very little instruction. I want to encourage the rest of you to pay attention to how she does it, because she's going to do a great job, and go ahead and volunteer to do one of these later on during the semester.
thank you. So hi everyone, and welcome to the first happy seminar of the year. It is my pleasure to introduce Professor Shelly Weizman, who will be speaking about addiction and mental health policy and law. Professor Weizman is a human rights lawyer who focuses on improving and advocating for the profession of public policy around addiction, mental health, and disabilities. She is an adjunct professor at Georgetown University School of Law. At the law school, she founded and teaches the Addiction and Mental Health Law and Policy course. The course examines the structure of law and policies that advocate for the human rights, respect, and dignity and recovery for individuals with substance use disorder and mental health conditions. Professor Weizman works as the director of the Addiction and Public Policy Initiative at the O'Neill Institute for National and Global Health Law. Professor Weizman currently serves on the board of directors of Faces and Voices of Recovery. Additionally, she coordinates discussion through the Recovery Policy Collaborative that promotes the creation and implementation of substance use disorder policy, as well as hosts a supportive network of health, human rights, policy, and law professionals that have lived experience with addiction. She is on the leadership team that established the Interdisciplinary Master of Science program in addiction and policy practice. She has her JD with a concentration in health law and policy from Seton University School of Law and her BA from the University of Houston. She began her career as a civil rights attorney and activist at MFY Legal Services, where she sued the government on behalf of her clients. Following her work at MFY, she went on to work for the state of New York's government. On her first day working for government, she walked into the office, and her coworkers who she had previously sued gave her the "what are you doing here" look. At the time, Professor Weizman believed that working for the government was like working for the evil empire. However, she found that there are many people in those positions who truly do care about changing the system, and that a great deal can be accomplished from working inside the system as well. She always encourages her students to work in public service at some point during the career because of the positive impact that she experienced during her time in government, which in turn made her a more well-rounded advocate. Professor Weizman's involvement in the field stems from her own personal experience of going through these systems as a child and then working in them as an adult. Her passion for pursuing a legal and policy career in addiction, mental health, and disabilities came from witnessing the numerous inequalities in this area and the ability to provide help to multiple people at once by attaining a legal education and skills. Thank you. And yes, now to Professor Weizman.
Great. Thank you so much, Sophia. That was a great introduction. So wonderful to be here speaking to all of you. Thank you, Professor Myers, for inviting me. And welcome to Georgetown, everybody. I understand this is one of the first classes, and it's really, this is such a unique and important program, the Happy program, and I'm just so glad to be able to participate. So I have a slide deck that I'll pull up, but before I get started, you know, this is a huge topic, addiction and mental health law and policy. As Sophia mentioned, I teach a whole class on this at the law school. I'm actually going to be teaching a class on this at the graduate school in the spring through the Addiction and Public Policy Master's program. And it's available as an elective for Happy students and other students. So if this topic interests you, you know, reach out to myself and Professor Myers, and we can see about getting you a slot in the full course. So, you know, I wanted to preface this talk by kind of saying that this is a pretty enormous topic, and I tried to give an overview. There are whole giant chunks of, you know, really important building blocks and information that I'm not even going to touch today. And, you know, as Sophia mentioned, also, I have a personal passion for this work, and I've been in this field a long time. And despite the, you know, difficulties that we see every day, there certainly has been a lot of progress and hope to be had. So let's share the screen. Okay. Can everybody see that? Yes. Okay, so here's my contact information. Folks can feel free to email. Email's probably the best way to reach me. If you want to talk more about any of these substantive topics, if you want to talk about career stuff, anything like that, you know, always happy to do that. So I was going to go around and have everybody do a little introduction, but I think that might take a little too long. So I'll ask if folks can put in the chat, you know, your name, and if you're a student, and what generally interested you in pursuing this degree. And if you had any kind of specific interest in mental health or addiction, that'd be good to know. And I'll try to kind of read those as we go. And also, if people have questions as we go, you can put them in the chat, and hopefully Sophia, because I can see you, maybe do a raised hand, and then I can kind of have you moderate questions. But I encourage questions as we go, and of course there'll be some time for questions at the end. So before we kind of get into it, I wanted to kind of have folks think about this framework that, you know, when we're answering these questions, which I think is really the work of policy advocacy or policy reform, how can we improve people's lives? How can we improve society? How can we do better? There are really kind of a few overlapping themes to keep in mind always. And I don't think that these are unique themes to the addiction or substance use space or the mental health space, but they're definitely are on point for this space. One is that the systems that touch these issues are complex, they're overlapping, but they're also siloed. So when we think about what of our systems touch on addiction, touch on mental health, we can think of many, right? Of course, treatment and the like traditional medical systems, but also criminal justice, child welfare, housing, economic development, and on and on and on. And very often these systems are quite siloed. And so that's a thread, a really important thread to consider as we talk about this work. The second piece is that there's a tension and a balance between people's individual rights and freedoms on the one hand, and the role of government on the other hand. So government is responsible for public safety, keeping the public safe, keeping people safe. And sometimes there's a real tension between that and people's individual rights and liberties. And we're not going to get into kind of the depth of people's constitutional rights in this space, but today, but that's a real key theme. And the third piece is that maybe more than in some other kind of policy areas, but certainly in this space, kind of personal beliefs, personal narratives, and public rhetoric really shape the law and policy in this area. So what we see in the newspaper, what we see on the news, the language people use, how people talk about people with mental illness or people with substance use disorder, someone's personal experience with that, whether it was positive or negative, really can shape the policy in this area. So the question really is, what are the levers and where can they be pressed? I think just yesterday, a new life expectancy update came out, and life expectancy is on the decline. Even before COVID, life expectancy had been on the decline for 3 consecutive years. And, this most recent decline was really, impacted by COVID, but the previous numbers really had to do with a significant increase in overdose deaths, suicides, and liver disease, which is often caused by alcohol consumption or alcohol use disorder. And this has been the longest consecutive decline in the American lifespan since World War I and the Spanish flu epidemic kind of coalesced in the early 1900s. So pretty significant what we're seeing, pretty significant impact on US society. And how did it get to this? How did it come to this? And we're not on the way up, right? So a little history first. I'm going to start with, the 1960s, John F. Kennedy. This was following some exposés and other kind of press attention and public attention on the conditions facing people with mental illness and people with developmental disabilities. And President Kennedy signed into law a pretty large and broad scale kind of mental health reform initiative. And that was really the beginning of this kind of old paradigm where people were warehoused in extremely large psychiatric institutions to kind of start moving people to more community-based services and improving conditions in those institutions. It was followed by Jimmy Carter and a commission on mental health, which really focused on self-determination, freedom, autonomy, dignity. There were some big ideas put out there in the Carter administration. So we also saw new kind of medical, I guess we'll say new attention to mental health conditions from the medical community, and investments in medications, investments in a safety net, in Medicaid and Medicare to pay for treatment. And so what we really saw over a period of time was a decline in the number of people housed in these kind of large institutions, a pretty steep decline, and an increase in community-based services, treatment, crisis response, peer support, other types of services. So, on the one hand, it looked like there was a lot of progress being made, and a lot of progress has been made in this space over the last 50 years. But that progress was tempered by some what we call trans-institutionalization. So as we kind of de-institutionalized large psychiatric hospitals in the 1960s and 70s, we started seeing people with mental illness going into what are called board and care homes, which could also be large kind of pseudo institutions, congregate living, nursing homes, and of course, jails and prisons. In fact, we really saw, this graphic, I think, really kind of illustrates what we've seen happen, that yes, there has been a real steep decline in these kind of large warehoused institutional settings, which didn't do very much to improve people's lives, but a large increase of people who were incarcerated. Meanwhile, of course, we're going to talk about addiction, or substance use disorder is the medical term. Meanwhile, we've had an overdose epidemic that over the past 20 years has really just exploded. This is interesting. This is a graphic that I used when I first started, not when I first, but several years back when I was doing these types of presentations. So this is, of course, Cowboy Stadium. It'd be great to see in the chat just people's guesses of how many people can this stadium hold. Let's see some, just best guess. All right, we've got 20,000, 35,000, 20,000, 40,000, 20, 60, 50. Okay, great. So this is actually, I think almost 80,000, almost 80,000 people that can fit in Cowboy Stadium, which is one of the largest professional football stadiums in the country. And when I first started, doing this lecture a lot, this was the illustration of how many people were dying of an overdose in the US every year. And this was maybe 3 or 4 years ago. The number now can't possibly fit in the stadium. It's, I think at last count, almost 108,000 people a year. That's like a plane full of people every day. Like in the time that we have been on this, Zoom discussion, probably at least 2 people have died of an overdose, and many more, probably 10 more, will die before we're done with this lecture. So we're really talking about an explosion of overdose deaths that's been exponential in the last, several years in particular. Who remembers this graphic? Few people. Sophia said yes. Adam. Yep. Matt, thanks. Yeah, so this is what, this is Ella. Yeah, this is from, I think, what many people remember either growing up or, earlier on in your careers, that this is what we would see, an egg. Someone would say, this is an advertisement. This is your brain. And then they would crack the egg and sizzle in the pan. This is your brain on drugs. That's the graphic that I think a lot of people think of. Well, this is really where we are now. The whole kitchen is on fire. The whole house is on fire, in fact. We're really in a problem. And that's because we have, and I'm not going to kind of go in detail, but what started with a prescription opioid crisis that led to a heroin crisis, and now synthetic fentanyl, which has really poisoned the drug supply in the US. We're having a spiraling and exponential number of deaths. And we're even seeing kind of a fourth wave coming. So, the things that maybe worked back in these days are not working as a response. And, it's debatable whether they worked even then. And, why is this? Well, we're going to get into that, but this is a pretty old graphic, but it's still pretty much where we are, that 10% of people who need help get it. What happens to everybody else? Well, you can guess. A lot of people go to jail. In this country, we've really adopted quite a punitive response to addiction and drug use. And what we're seeing, again, it's not working very well. So how did we get here? Well, this is a nice big list for you guys. The takeaway is that we got here not by accident, by a series of legal, law, and policy choices that we've made. Some of them have been data-driven, science-driven, and have really kind of helped move the dial on improving the system. And others have been driven by politics, by stigma, by discrimination, by racism, and we have moved us in a backwards direction. So, a couple highlights here: over 500,000 people in psychiatric hospitals in the 1950s, which is a lot of people. And I think, then President Kennedy, we have the Community Mental Health Centers Act, Medicaid, all those things we talked about, Jimmy Carter. Well, then in the 80s, we had a bit of a step back. We had a repeal of the mental health, some of the Mental Health Systems Act that were implemented in the Carter administration, and a block grant, which means like a finite amount of money going to states to help support mental health and addiction. That coupled with increases in the use of managed care and insurance, started kind of limiting some treatment options for people. So we kind of moved a lot of people out of these psychiatric hospitals, and then a community-based system that was envisioned did not grow to kind of help those folks. And so we had an increase in where do those people end up, right? Jails, unhoused and homeless, and started losing a lot of people. So then we had the Americans with Disabilities Act, protection and advocacy. This is a legal and advocacy for people with mental illness. 1994, significantly less people in psychiatric hospitals. Olmstead v. LC, this is a seminal Supreme Court case that was about deinstitutionalization, about moving people who didn't need to be hospitalized out of the hospital into the community. In the year 2000, obviously very significantly less number of people in psychiatric hospitals, but what do we have? A lot more people incarcerated. So it's not linear, I think, what we can see. And every single kind of law that was passed or policy choice had an impact, right? So we have kind of this up and down. And, as mentioned, a lot of racialized policies, racist policies, discriminatory policies really led to a disproportionate impact of these law and policies on communities of color, also Indigenous communities. We have sentencing disparities for different drugs, crack versus cocaine, for example, mandatory minimums, and this is a spiraling impact. It impacts families, it impacts communities. There are collateral consequences of discrimination. We've had disability discrimination, housing discrimination, and all of these have been policy choices. There's also significant racial disparities in access to care and treatment. In general, treatment's difficult to access. For people of color, it's exponentially more difficult. These are graphs about buprenorphine, which is also known as Suboxone. It's a medication to treat opioid use disorder. Once has started to be a huge push to get people access to this treatment because it is an evidence-based treatment. It has a significant reduction in overdose once people start to receive treatment. Well, you can see here who's getting treatment: white people. And so there are real significant and challenging disparities. Meanwhile, I don't have the graph here, but the highest increase of people who are dying of overdose, particularly now, are Black and Indigenous communities. And so, of course, mental health and addiction, these are real intersectional issues. I mean, here's a big giant list, and it's probably not even close to the whole list of, what are the different things this intersects with: genetics, health, social contracts, of course, racism we talked about, mass incarceration, but also whether people have social and economic mobility, personal trauma, generational trauma, purpose, community, all of these things that touch on these issues, social determinants of health, and more. And so starting to unpack and solve these issues is very complicated, because when we look at what are the root cause, how do we, there's a saying about going upstream to pull people out of the river before they fall in. Well, it's very complicated. There are a lot of complex factors at play here. So what do we do about it? Where do we go from here? What we're starting to see is a new approach, a public health approach, where we look at the science, we look at the evidence, and we say, what's going to work based on research, versus a punitive approach, which is an approach that centers the correctional system, that centers police, that centers public safety as the goal, rather than public health as the goal. Another thing we're seeing is, and we've been seeing this for a long time, but I think we're seeing it accelerate, is to kind of maximize these protective legal and policy frameworks, which we'll talk about. What are the laws that have the potential to make reform? And there are many. And so maximizing those through litigation, which is lawsuits, legislation, state laws, federal laws, finance. I'm not going to go too much into kind of healthcare finance, but I'll just say that is an enormous lever for reform. And for everybody in here who wants to have a career in health reform or public health reform, I can't, if you take nothing else away from this entire lecture, please take this away. You have to understand the money to change the policy. If you don't understand the money, it's like your hands are tied behind your back. Everyone can have great ideas all day and night, but if you don't know how the money works, you can't pay for them, and it all costs money. So, I will put in that plug to learn how the money works. And that rings true for these fields, mental health and addiction, very much so, because any reform is going to cost money. Can't just move money from jails to treatment. It's complicated, much more complicated, for example. So, and then changing the narrative, activism, political pressure, and press. There's nothing like a bunch of moms, marching in the state capitol, and a front page story on the New York Times. Say New York Times because I worked in New York for the governor. And if there was a bad story in the New York Times, you better believe we got a phone call at 4 a.m. So, I always as a lawyer, of course, I always think that the 1-2 punch of litigation and bad press is the surest way to start making a change. And then, of course, addressing the social determinants of health. So, a public health approach. Well, okay, like what does that even mean in like practical, real life? So as an example, talk about a case study. So I don't know if people read the Dade County article. There are a lot of issues at play there, and we'll talk about that hopefully a little bit at the end of the lecture. But so just taking mental health and addiction in correctional settings, right? Because like we said, a lot of people end up there now. What does it mean to opt to have a public health approach? Well, one means have people not go to jail in the first place, right? We call it diversion. That can look like drug courts or mental health court, where people enter a program or receive treatment instead of going to jail, or deflection, which could mean not being involved in the criminal justice system at all. There are some models out there that are pre-arrest diversion. So the person doesn't even have something on their record. They go to a stabilization center. They have a connection with a peer, that's somebody with lived experience who's trained in how to help people navigate these systems. Because what the data shows is that going to jail does not solve or resolve somebody's mental health condition or substance use disorder. In fact, it exacerbates it because it's quite traumatizing and re-traumatizing to be incarcerated. And often treatment is not offered, or quality treatment is not offered, as we saw in the Dade article. Another example of a public health approach here is immediate access to treatment at the appropriate level of care. So that means before it even comes to an arrest or being justice involved, that people should be able to have access to treatment when they need it. Right now, that might be available in some places, but in a lot of states, counties, cities, there are long waiting lists, or people have to call all around. There are insurance barriers, other access barriers. And so it might look, a public health approach might look like having a clear way to access treatment. Another idea, immediate and ongoing care and evidence-based treatment in correctional settings. So actually providing evidence-based treatment to people when they're incarcerated. So you have a little quote here on the right. This is from Sheriff Apple. He's a sheriff in Albany, New York. He's talking about medications for opioid use disorder. That means methadone and buprenorphine, as I mentioned, also known as Suboxone. These are two medications that are for decades now proven to reduce overdose death and help people get their lives back. But they're heavily stigmatized, they're heavily regulated, and they traditionally have not been available in correctional settings. So Sheriff Apple said, I didn't believe in it, medication, but we were convinced to try it. In the first 3 months, we saw a reduction in diversion and recidivism, and it was saving lives. It's a no-brainer. So what he saw was that it was the same people coming back to jail, same people over and over again. But when he, as the sheriff of the county, said, all right, we're going to give people treatment, people stopped coming back to jail. He actually had to decommission 100 jail cells in his jail because people were just not coming back to jail because they got treatment. And now he goes around and talks to other sheriffs about this. And so that's an example of a public health approach, right? To say, all right, we're going to get people the treatment that we know works. Wraparound support, long-term support. We know mental health and addiction, it's not just a one and done. People need support for a long time, sometimes a lifetime. So having that available, and of course, support, not surveillance. So we mentioned maximizing constitutional and statutory protections. This is a list of, not exhaustive, as you see with the asterisk, of laws that offer protections to people. The Eighth Amendment, that's about cruel and unusual punishment. There's a Supreme Court case that says that the high level summary is that basically people have to be provided with medical care, and the correctional settings. So the correctional setting cannot disregard a person's medical needs. Otherwise, that's cruel and unusual punishment. And the Eighth Amendment has been used in quite a few lawsuits related to lack of access to mental health and addiction treatment. And the 14th Amendment is what extends those rights to making sure that the states and local government have to do that. So jails and prisons, not just federal prisons. Section 1983, which is the Civil Rights Act, that is the law under which people can sue for constitutional deprivations under the 8th and 14th Amendment. Americans with Disabilities Act, that's another one. Actually, the Justice Department just came out with guidance saying that those medications that I mentioned, methadone and buprenorphine, have to be people who are receiving those medications when they go to jail or prison, they have to continue receiving them while incarcerated. That was a huge new guidance, that an interpretation of the Americans with Disabilities Act, and a major tool for providing people with access to treatment. CRIPA, Civil Rights for Institutionalized Persons. This is the law that the Department of Justice uses about correctional settings. And then others like the IDEA, it's about education, fair housing. There's also state laws, civil rights laws, and human rights laws. So there's a whole kind of suite of potential laws and protections for people, and they're being used. They're being used by lawyers and advocates across the country right now to improve conditions and get people access to treatment. And a lot of those times it happens through litigation, basically lawsuits against either brought by like a nonprofit organization on behalf of clients, like the ACLU is doing a lot of this, or brought by the Justice Department, saying that, you know, people need access to care and treatment. So these are some examples. This Bureau of Justice Assistance legal brief, this is something that we worked on at the O'Neill Institutes that the Department of Justice came out with. You have a New York Times article about somebody who wasn't able to access medication in prison. And then on the right is a report that we came out with about access to treatment behind the walls. And these are just examples. A lot of different ways to make reform. Enhancing and improving these also protective policy frameworks. So a right to counsel, it means a right to a lawyer. Now we have a right to a lawyer in criminal cases, but there's been movement to appoint a lawyer if somebody's getting evicted from their home, and that often disproportionately impacts people with mental illness. Medicaid coverage and other kind of financial and fiscal levers. We talked about that. The money is very important. Supported housing, that's housing in the community with wraparound services. Having that, more of that. Drug courts and mental health courts, not just more, but ensuring that they are quality, that prison and jail is not used as punishment. Other alternatives to incarceration, patients' rights. So a lot of different kind of policy frameworks that offer opportunities for reform. Okay. And then, you know, political pressure. I mean, we have President Biden out here in the State of the Union talking about mental health. This is the first time that it had ever happened. Talking about mental health, talking about recovery from substance use disorder. I don't think any president had ever used the words recovery or harm reduction in the State of the Union. I mean, huge. But why do we think that happened? I'll let you all ponder on that and maybe come up with some answers. Why do we think that all of a sudden President Biden's talking about mental health in the State of the Union. And then, of course, our New Yorker article on the Dade Correctional Center. We could have some discussion about that, but what are the tensions here? What are some policy tools? What's the role of government? Kind of back to the themes that we talked about in the beginning. This is an article in the press. How might that have shaped some reform in this area, or did it? The person that wrote the article is now writing a book, or just published a book, which I actually haven't read, but I'd like to. So we can talk about that a little bit more. This is my favorite quote about human rights. So that's it from me. And I think it'd be great to have some discussion, take questions. I know it's kind of a little more difficult, not in person, but and I'll take a look at the chat also and see what we have. Thanks, everybody.
Okay, great. So Sophia is going to be moderating the Q&A session. I just remind you this time, I won't remind everybody every week, but that we start out with students, and then other folks are welcome to raise their hand and be called on later on during the Q&A session, or put them in chat. So Sophia.